I'm Dr. Keith C. Ferdinand, the Gerald S. Berenson Endowed Chair in Preventive Cardiology and Professor of Medicine at Tulane University School of Medicine in New Orleans, Louisiana. I'm pleased to discuss the polypill and other innovative approaches to risk factor management. Here are my disclosures. This is a review from Scotland showing that in persons 65 to 74 years of age, as many as 12% have been prescribed 10 or more drug classes. And with older populations, that percentage of persons actually increases. So when is polypharmacy actually appropriate? Well, all drugs should be achieving a specific therapeutic objective, which has been agreed upon with the patient. Therapeutic objectives should be actually being achieved or a reasonable chance that they will be achieved in the near future. There should be some effort to optimize therapy to minimize adverse drug reactions, and the patient should be motivated and able to take all medications. The need for cardiovascular patients to take many medicines led to the concept of the polypill. Here is a suggestion that perhaps 80% or more of cardiovascular disease can be decreased by Wall, published in the British Medical Journal in 2003. The suggestion was to have a polypill that had a statin, 3 blood pressure medicines at 1/2 dose, folic acid, and aspirin. The concept of Wall, along with Law, was that you can intervene on 4 risk factors and reduce by 80% myocardial infarction and stroke. But in order to achieve this population effect, you would have to require the treatment of all persons above a specified age, they suggested 55, or younger persons who had arterial occlusive disease. This combination pill, therefore, would need to be used widely. It should be noted when they wrote this opinion piece in 2003, they suggested that each component had been used in medical practice for greater than 10 years and has substantial evidence of safety and efficacy. We now know that all patients can't tolerate aspirin. It is not indicated for primary prevention. Other forms of antiplatelet therapy may be more efficacious, and no one recommends folic acid for usual use. Subsequent to that, Wiley and Fuster did a review in which they looked at the polypills that were available in 2012. These were approved globally, only one in Europe, the CNIC pill from Spain, which does show some cardiovascular outcomes benefit, and we'll discuss that shortly, and another from Iran, the Polyiran, which also has been shown to show cardiovascular outcomes protection. There's no polypill that's been approved in the United States by the FDA. Wiley and Fuster therefore suggested that the polypill may actually address a treatment gap for cardiovascular secondary prevention, that it would simplify treatment algorithms, that it would reduce non-adherence. And I think this has actually been shown in multiple studies with various polypills. And it may improve access to medications in countries lacking adequate healthcare infrastructure. I'll discuss with you in a moment one study that showed a decrease in systolic blood pressure and LDL cholesterol in a disadvantaged population in the United States, although it was not an outcomes study. I mentioned earlier that the polypill does appear to increase adherence, and here are multiple studies that have shown versus the usual difficulty maintaining adherence over 12 to 15 months, a marked increase in adherence with the use of the polypill. Perhaps the first study to show a benefit in terms of cardiovascular risk reduction with the polypill concept was the Heart Outcomes Prevention Evaluation, or HOPE-3. This was a large trial, over 12,000 patients, 46% female, mean years in terms of age of 65.7, and followed for over 5 years. The principal investigators were Youssef and Long. In the design of the HOPE-3 polypill study, this was the first formal testing of clinical event reduction with the polypill, a double-blind 2x2 factorial design, placebo-controlled, in patients who did not have demonstrable cardiovascular disease and were at intermediate risk. Rosuvastatin significantly reduced cardiovascular events, but the combination blood pressure medication only reduced cardiovascular risk in those who had elevated blood pressures greater than 143 millimeters of mercury. Here's the combination of the HOPE-3 polypill, a moderate dose of rosuvastatin, 10 milligrams, combined with a moderate dose of an ARB candesartan with a very low dose of HCTZ, 12.5 in one pill. It should be noted that 12.5 milligrams of hydrochlorothiazide has not been shown to have cardiovascular protection in any clinical trial. The entry blood pressure was 138.1 systolic, an LDL of 127.8, excellent retention throughout the trial, and a heterogeneous population, although only 2% of them were self-identified as Black. Here's the design in terms of the various groups: rosuvastatin plus the candesartan HCTZ compared to a double placebo, rosuvastatin compared to placebo, and the candesartan HCTZ compared to placebo. Again, as had been noted in other polypill studies, an excellent retention in terms of compliance. The rosuvastatin did significantly lower LDL cholesterol, apolipoprotein B, and C-reactive protein across the length of the trial. All of these differences were statistically significant. In terms of outcomes, there was an improvement in the second co-primary outcome using rosuvastatin with significance less than 0.001, decrease in stroke, decrease in myocardial infarction, and a decrease in coronary revascularization. The blood pressure of candesartan and hydrochlorothiazide reduction did show significance of 6 millimeters of mercury plus or minus 13. However, there was no reduction in the second co-primary outcome, no reduction in other outcomes, myocardial infarction, stroke, or coronary revascularization when compared to placebo with the blood pressure component. It should be noted in the forest plot that is listed here, for those patients who had a systolic blood pressure of 143.5 or greater, there was, however, significant reduction in both the first and second co-primary outcome with the candesartan hydrochlorothiazide combination compared to placebo. Now, the true polypill not only has the blood pressure components, but also lipid lowering. So the combined therapy here is compared to double placebo, both the rosuvastatin and the blood pressure components in one pill. Indeed, it did demonstrate improvement in the second co-primary outcome, improvement in stroke, myocardial infarction, and coronary revascularization. So overall, the polypill concept showed that the combination of rosuvastatin at a 10 milligram dose with candesartan 16 milligrams and HCTZ at 12.5 in one pill compared to a double placebo significantly lowered the rates of cardiovascular events among persons who had intermediate risk and did not have demonstrable cardiovascular disease. A more recent trial that showed benefit with the polypill concept was the Poly-Iran study. Over 6,800 patients, 50% of whom were female, 10.8% with pre-existing cardiovascular disease, most of whom were taking medications, and again, a very robust adherence of over 80%. The polypill in Poly-Iran was a very low dose hydrochlorothiazide, which is frankly suboptimal, low dose aspirin, moderate dose of atorvastatin, and a very low dose of enalapril with valsartan for those patients who had a cough with the ACE inhibitor. In terms of the blood pressure effect, it did show statistical significance at 24 months. However, it was not seen at 60 months, probably because the minimal care group more effectively lowered blood pressure compared to the polypill group. The change in LDL remained statistically significant throughout the trial, both at 24 and 60 months. Most importantly, there were several outcomes which were lowered with Poly-Iran polypill, including fatal ischemic heart disease, non-fatal ischemic heart disease, fatal stroke, and non-fatal stroke, all statistically significant. Some other secondary heart outcomes were not shown to be beneficial, including sudden death, heart failure, and overall mortality. In the United States, there is no polypill which has been approved. However, this study from the Vanderbilt group suggests that there may be benefit in lowering systolic blood pressure and LDL in underserved populations. In a sample size of 303, 96% Black, 75% had an annual income less than $15,000. They were enrolled from an Alabama federally qualified community health center with a 10-year risk of 12.7%. Mean baseline systolic blood pressure 140, LDL 113. And the cost of the polypill approach was $26 a month. Again, as has been seen in other of the clinical studies with the polypill, adherence was high at 86%. The polypill in this study, compared to usual care, was atorvastatin, low-dose amlodipine at 2.5, low-dose losartan, and a very low-dose HCTZ, compared to usual care in an open-label, randomized, controlled approach. The two primary outcomes, systolic blood pressure and LDL cholesterol at baseline, both were significantly lowered. Although this was not a cardiovascular outcomes trial, by lowering the systolic blood pressure and lowering the LDL cholesterol significantly, the author suggested that the polypill strategy may be important in terms of reducing both the systolic blood pressure and the LDL compared to usual care in a socioeconomically vulnerable minority population. So the question is, what will be the utility of the polypill in the future? What does the future hold? Well, we don't know. No one could have predicted the COVID-19 pandemic, the economic distress, and the difficulties that we've seen in the United States with racial strife. The optimal composition of the polypill, therefore, in the future may include more potent drugs at higher doses. We will probably need to have 2 or 3 antihypertensive agents because it's now been suggested, and this is from the 2017 ACCHA high blood pressure guideline, that most middle-aged and older patients need 2 drugs or more, and this is especially true in the African-American population. Should aspirin be a regular component? Probably not if you want to use it for primary prevention, and even with high-risk secondary prevention, there's some data that aspirin is less effective than other forms of antiplatelet therapy. Should anti-diabetic drugs be included? Well, it may actually complex the construction of the polypill itself, although we know the SGLT2 inhibitors have increasing data in terms of protection against rehospitalization for heart failure and overall cardiovascular disease, along with renal protection. Other components, such as vitamins, probably should not be included. In terms of the use of the polypill, this is one suggested opinion piece published this year that said that in multi-pill therapeutic strategies, switching to a polypill-based strategy may actually help in terms of cardiovascular protection in patients with hypertension. Remember, the CINC pill is approved in Europe. It has since been shown to be effective for cardiovascular risk reduction and is now available in 6 different formulations, including both a moderate and high dose of atorvastatin and 3 possible doses of ramipril, the 10 milligram dose of which has been shown to have a decrease in cardiovascular events. What's suggested by the authors in this opinion piece is that those persons with previous cardiovascular events will need multiple medicines to decrease cardiovascular risk. In that setting, with multiple medicines being utilized, it may be reasonable to combine in a polypill approach low-dose aspirin, appropriate dose of atorvastatin, and ramipril, along with other drugs for specific comorbidities. If additional blood pressure would be needed, an addition of a diuretic or calcium channel blocker could be entertained. And in those patients who do not reach a goal of a blood pressure less than 130/80, or an LDL less than 55, which is suggested in very high-risk patients in Europe, adding other medicines, including ezetimibe or even a PCSK9 inhibitors, along with additional blood pressure medicines, may be beneficial. In the COVID-19 era, we now know that healthcare has been disrupted. In this opinion piece from Floyd and Wierzbicki, they suggest that the polypill may help alleviate some of the distress in terms of healthcare with COVID-19. COVID-19 pandemic has delayed routine cardiovascular risk reduction screening and follow-up appointments, and patients have been delayed for months associated with potentially cardiovascular outcomes which are deleterious. They propose that the routine use of a polypill should be considered in light of data showing beneficial surrogate and cardiovascular disease outcomes. So in conclusion, in terms of the polypill and other innovative approaches, we can suggest that it may be beneficial, but will need high-intensity statin and more intensive antihypertensive regimens in the future. Lower doses probably will not be as acceptable in high-income societies. We now know from the observational and clinical trial data that lower is better both for the LDL cholesterol and for hypertension. The addition of aspirin is reasonable for secondary prevention, but somewhat complicates the medication construction of the polypill and limits flexibility. And for most patients, the antihypertensive and statin therapy will need to be adapted to the hypertension grade and the LDL level of the patient who is at increased risk. Thank you for this opportunity.